I want to thank Donna for inviting me to tell you about the work of this group and what it's been doing for 26 years to save kids' lives in North Carolina. So I came into my role as director of the task force 2 years ago. And because my background was in juvenile law and I had actually worked for one of the founders of the task force, I was familiar with this group's work. I knew generally the kinds of issues that the task force addressed and that it had been successful in advancing some public policy to positively impact kids. What I didn't realize until I really dug into this work, however, was the critically important role that the task force has played for over a quarter of a century in North Carolina in really getting the right people around the table to study and discuss the data and the causes related to child death, and to make a broad range of recommendations that have not only made an impact in North Carolina in preventing future deaths, but have frequently made North Carolina a national leader in public policies that promote child health and safety. So for today's presentation, I want to talk to you a little bit about the task force's role, our responsibilities, our membership, our process. And I'd like to talk to you about the use of data to inform our work. And I'm going to be providing you with examples of data. And then I also want to weave in examples of some of the recommendations and actions that the task force has taken to prevent child deaths and promote child safety and well-being. So as Donna mentioned, we are a legislative study commission, and we were actually created in 1991 by state statute. We are considered to be the policy arm of the state's child fatality prevention system, which I'll talk more about in a moment. We have 35 total members, consisting of experts, state and local government representatives, legislators, which I'll explain more detail about in a moment as well. And one of the fantastic things about this group is the folks who sit on the task force and on the committees have really big, busy jobs. And they find the time to come and meet and hear from experts, talk to one another, and to do this work. So about 1,000 hours of volunteer time goes into crafting the task force agenda every year. So the state child fatality prevention system that I referred to earlier, that's according to Article 14 of the North Carolina Juvenile Code. The point of the child fatality prevention system as a whole is to have a community-wide approach to addressing child abuse, neglect, and fatalities. The system is charged with studying and understanding the causes of childhood deaths in order to identify gaps in service delivery systems that are designed to prevent child abuse, neglect, and death. And the purpose of that study is to be able to make and implement recommendations for laws, rules, and policies that will support the safe and healthy development of children and prevent abuse, neglect, and deaths. There are three main components to the child fatality prevention system. This doesn't explain everything involved in the system. It's actually fairly complex, but it gives you an idea. There are 2 types of local child fatality review teams, and there's also a state child fatality prevention team, which is also known as the state team, and that's chaired by the state's chief medical examiner. Then there's the child fatality task force, which does not review individual fatalities, but deals with policy only. These state and local fatality review teams, as well as the task force, are made up of a broad range of folks, from social services folks, law enforcement folks, school people, public health people, mental health people, court people, and the list goes on. It is truly a community of people who come together to study what's going on with respect to child fatalities and ask themselves, what's going on? How can we do better? The state team makes recommendations to the task force based not only on the cases that they review themselves, but also on recommendations that might be made to them from local teams. And most of the local team recommendations are actually local in nature, but recommendations that have some state level significance may make their way to the task force through the state team. So what does the task force actually do? Well, besides taking in recommendations from the state team, which is actually a fairly small part of what we do, we study our state's data on child fatalities. And we also take in a lot of other data and research and program information related to child deaths and strategies to address preventing them. As a group, the way we receive that information is mostly in the form of expert presentations at our meetings. We use what we learn to determine recommendations that we can make to the governor and the General Assembly to impact laws and policies to prevent deaths, abuse, and neglect. I wanted to give you some more detail on task force members because this is a critical part of how we're able to accomplish what we've been able to accomplish all these years is really the makeup of the task force. And this is just the first page. So there are 4 task force members that are appointed by the governor, county DSS director, a SIDS expert, that's sudden infant death syndrome, a representative from NC Child, local public health director, and you can see the others on the side there that include a pediatrician, a representative of the League of Municipalities, domestic violence representative, and then 5 members of the North Carolina House of Representatives. So that's 5 of our 10 legislators. And then, this slide has gotten a little bit messed up. But anyway, you've got 10 appointed by the Senate President Pro Tem, and that's a county or municipal law enforcement officer, a district attorney, a representative of county commissioners, another domestic violence representative, a public member, and 5 members of the North Carolina Senate. So that's 10 legislators altogether. And then also importantly, there are 11 ex officio members. And these are folks that actually represent leaders of many of our state agencies. So the chief medical examiner does not have a designee. All of the other representatives of state agencies are allowed to have a designee who actually represents them in their seat on the task force. And you can see that we've got the Attorney General, Director of the Division of Social Services, the SBI, Superintendent of Public Instruction, Director of the Division of Mental Health, the DHHS Secretary, and the Director of the Administrative Office of the Courts. So quite an array of representatives. We're able to bring a lot of folks who are actually able to get things done in state government around the table to talk to one another and identify these gaps and issues and things that we might be able to improve on. So the task force actually accomplishes much of its work through 3 committees who have the primary goal of creating a yearly action agenda. We have the Perinatal Health Committee that deals with healthy birth outcomes and a wide range of issues on that committee. We have the Intentional Death Prevention Committee, which deals with homicides, suicides, and abuse and neglect. And then we have the Unintentional Death Prevention Committee, which deals with accidents of all types. That could be motor vehicle accidents, drownings, poisonings, fire, things of that nature. Each of these committees meets and comes up with recommendations that it wants to move on up to the full task force. And a recommendation only becomes a task force recommendation once it's approved by the full task force. Something that's good to be aware of is that the task force committees are made up not only of statutory members of the task force, but there are also folks out there in the community who have expertise or interest in the kind of work that takes place in the committees that are also on committees. So it draws from a broader range of experts and interested folks to contribute to what we learn about and what we pass on. The way we do our work, and of course this is sort of the very quick nutshell version, but we're only permitted to meet between legislative sessions. Because we're a legislative study commission, these meetings are public, and we call our meetings between session a study cycle, and during that study cycle we have about 3 to 4 full task force meetings and around 2 to 4 committee meetings for each of the 3 committees. Our proposed issues for review might come from those local and state teams, as I mentioned earlier, but we also have trends that are identified by data. We study the data, and if there's a trend that we feel we need to react to, that might be an issue that we focus on. And then we also have an issue application process that was started in recent years. And that allows, really, it's kind of a level the playing field kind of a situation that allows any kind of group to submit an application that tells us why they think there's an issue that we should be focused on or a program that we should consider supporting. And so we take in those applications and our executive committee deals with them, and they get assigned to committees, and then an issue might run through the task force through that process as well. And then we have, from time to time, we convene stakeholder or study groups, some types of work groups to address or examine in depth a particular issue. And that's an example of how we met Becky Gray. We convened a group that is a broad range of folks that were asked to come and help us come up with ideas and contribute to some of the work we were doing. And Becky Gray was asked to join us in that group. Very importantly, and I can't emphasize this enough, ongoing information sharing and collaboration among experts and community partners. You can imagine when we provide a forum for folks to sit in the same room with folks they might not normally sit in the same room with, and hear expert data, hear presentations, and be able to ask questions to those experts, be able to have discussions, engage in discussions. It's a wonderful forum to be able to understand who else is out there working on a given issue. Who should we be collaborating with? Who can we learn from? And so it really is an excellent place that kind of forms a forum for ongoing work and collaboration. So, each year's annual report from the task force contains not only data on child deaths and recommendations for the year, but it contains a list of year-by-year accomplishments of the task force that takes up several pages of that report. So this one slide is really just a few highlights among many to give you an idea of the kinds of things that we have worked on. The graduated driver's license program and various other teen driving safety measures has really been pivotal. North Carolina, most people don't realize it, the GDL system was developed here, and we were the first state to enact it. And the earliest examination of the effects of the GDL found a 23% reduction in minor crashes and a 57% reduction in fatal crashes among 16-year-old drivers. Long-term studies showed that 16-year-old crashes declined by 38%, while fatal and serious injury crashes declined by 47%. So that gives you an idea of public policy that really has saved kids' lives. Child passenger safety laws, the reasons that kids are in safety seats of a certain type and for as long as they are at a certain weight or age, that has a lot to do with the efforts of the task force. Measures to combat the opioid epidemic, which I'll be talking about more later. Those are some of the recommendations that we've made. Pulse oximetry screening for newborns, that's to detect certain congenital heart conditions. I won't go through all of these, but you can see laws addressing smoke alarms and CO detectors, support for programs providing child maltreatment, prevention, diagnosis, and treatment. These are all the wide variety and range of things that the task force has made recommendations on. So as I mentioned, one aspect of task force work is examining child death data. And each year, the State Center for Health Statistics closes out a year's worth of statistical data on child deaths, and the task force actually is the one that releases that data to the public. We examine that data in our meetings, and we do deeper dives into various aspects of the data to inform different issues that we're working on. This gives you an idea of some of what we look at. This is kind of a big picture slide that shows the leading causes of death, and this was actually in 2015. The top 3 causes of child death, as you can see, are perinatal conditions such as prematurity and low birth weight, along with illnesses and birth defects. And then we have unintentional injuries, the accidents that I referred to before. We have homicide and suicide. And I would note that in 2014, suicide was actually above homicide. They actually were reversed in 2015 based on the numbers. But that gives you an idea of sort of the broad picture of what we look at. We look at how the numbers break down by age. And you can see that deaths to infants, and that's babies under 1 year of age, made up 66% of total child deaths in 2015. And deaths to children under the age of 5, which includes infants, accounted for 78% of all child deaths. And then our next most vulnerable age group is 15 to 17, those older teens. Yes, sir?
Do you have any figures on the ages of the parents?
We actually, that is something that could potentially be an example of a deeper dive in data if we were to think that at some point that was relevant. It's not something that we get into with our initial overview of the child deaths each year.
The reason I said that is because in your earlier foil, you showed about the trend with how things are going. And I would think, and what you're doing, like for example, you're required to make sure your child is safe in your car. I was thinking if you had the teenage parents who, when a pregnancy occurs, are required to go to certain classes, because I think a lot of these are accidental deaths. Like there was one a couple of weeks ago where a man was guilty of leaving his child in a car and they died because of the heat. They may not even be aware of the things they have to be, concerned about as early parents. So.
Well, certainly when child death reviews take place, those kinds of teams are able to dive into that data, and if there are recommendations surfacing from the kinds of trends they're seeing from that data, they may rise on up. But I do understand what you're saying. Yeah. So we look at how the numbers break down by race and ethnicity, and there we go. The red line represents the total of all children. You can see that red line there in the middle. The green line near the top of this chart is the rate for non-Hispanic African Americans. The yellow line is American Indians. The purple line near the bottom of the chart shows the rate for Hispanic and Latino children. The brown line is white children, and then blue is all other. And I know that can be hard to read, so I wanted to go ahead and let you know what those lines represent. And you can see that this chart demonstrates that while the gap in racial disparities has tightened somewhat, disparities still remain. So we have work to do, and the task force is very well aware of that and is mindful of it. This chart gives you a better picture of the ratios for those leading causes, and it really does illustrate the huge role that healthy birth outcomes play in overall child death rates. So with infant deaths accounting for over 2/3 of all child deaths, the work of our perinatal health committee is very important. Each year that committee, as well as the full task force, takes a very close look at the data related to infant mortality. And presentations on our infant mortality data in much more detail are available on our website, which is hosted by the General Assembly, if you're interested in taking a look at that. And as you can see by this graph, it shows that the infant mortality rate in North Carolina, which is the top red line, has stubbornly resisted decreasing in recent years, and it has in fact seen a slight increase. And the blue line shows the national infant mortality rate. Unfortunately, North Carolina's infant mortality rate ranks among the highest or the worst in the US. You can see that we are tied for 8th with Indiana. We also pay attention to geography. So this is a map that shows the 2015 infant mortality rates by perinatal care regions in our state. And you can see here that the worst rates, represented by the darker colors, are concentrated in the eastern part of the state. And as you can see with this map showing poverty rates, regions with the highest death rates also tend to have the highest poverty rates. So what kinds of strategies can we, as a state, as the task force, initiate to decrease infant mortality rates? There's no one silver bullet. It's a broad combination of strategies. And in fact, North Carolina has a bold, new, comprehensive perinatal health strategic plan. Some of you may have heard of that. It's designed in part to improve infant mortality rates, and this plan, to give you an idea of just how comprehensive it is 15 pages long with 12 main goals and multiple specific strategies within each goal. And there are various strategies within this goal that might relate to policy that the task force has addressed or will be addressing. So that gives you an idea of just how complicated these issues are when it comes to perinatal health. Some of the examples of past recommendations of the task force that are meant to address infant mortality include funding for the You Quit, To Quit perinatal tobacco cessation program. A lot of people may not realize that tobacco use during pregnancy is directly associated with the top 4 causes of infant mortality in North Carolina. Also, support for promoting infant safe sleep. That's teaching safe sleep practices to caregivers of infants, which is critical to reducing sudden infant death syndrome and preventing accidental strangulation or suffocation during sleep. And funding for the drug 17P, which is something that can prevent subsequent preterm births. The task force was actually recognized nationally for being a leader with support for this drug. So that was an important recommendation. Okay, so moving away from the topic of infants, I want to talk a bit about the unintentional and intentional deaths. The green line on this graph illustrates the trend data with respect to motor vehicle injuries, which are the leading cause of unintentional deaths. And you can see how much progress we've made in a 10-year period. The purple line represents other types of unintentional deaths. The blue line of this chart represents homicides, and the red line represents suicides. And you can see here that over the course of the last decade, suicide rates have crept up slightly, but rates of all other causes of injury have declined since 2006, with the unintentional motor vehicle accident showing the steepest decline. So with suicide rates that crept up and then spiked in 2014, the Intentional Death Prevention Committee has done some very focused work on youth suicide prevention in recent years. And that work involved delving into the data and hearing from experts on problems and solutions. Here's just a bit of the data that illustrates the problem that we're dealing with. Nationally and in North Carolina, suicide's the second leading cause of death for youth ages 10 to 17. There were over 300 suicide deaths to North Carolina children aged 17 and younger between 2006 and 2015. That's just 10 years. And then 9.3, almost 10% of North Carolina high school students surveyed in the Youth Risk Behavior Survey reported attempting suicide. And then in 2014, you can see there were over 1,600 emergency room visits and 513 hospitalizations for self-inflicted injuries among youth ages 10 to 17 in North Carolina. It's quite a problem, and it's something that the task force is paying close attention to. And after learning about the data and hearing from experts, the task force decided to form a work group that was composed of agency representatives and suicide experts who came together to determine what they thought would be the most promising and most urgent strategies to address youth suicides, and specifically taking into account North Carolina's statewide suicide prevention plan, which was developed in 2015 and was quite an undertaking involving the development of that statewide plan involved over 180 stakeholders contributing to it. And kind of like the perinatal health strategic plan, it's quite long and comprehensive. And so this group was tasked with saying, okay, what types of strategies evolving from that plan could agency leaders kind of come together and agree upon were urgent for youth suicide prevention. And this group included leaders from the Department of Public Instruction, Division of Public Health, Division of Mental Health, Department of Public Safety, the Center for Safer Schools, a local public school system, and NC Child. And this group reported back to our Intentional Death Prevention Committee, who then settled on the recommendations that it wanted to make to the full task force for last year, for 2017, related to youth suicide prevention. The first of those strategies was to require suicide prevention training for all school personnel, and to have a risk referral protocol for students identified as being at risk. Adults in the school setting may be in the best position to spot a problem with a kid, but they need to know what to look for and how to appropriately guide that student for needed resources. And many other states have actually already required some type of suicide prevention training in schools, so it's not a new concept. There was legislation introduced in North Carolina in 2017 that really did take up this recommendation on requiring suicide prevention training in schools. However, it easily passed the House, but then it stalled in the Senate. So it will still be eligible for consideration in the short session, but that's the status of that recommendation. The next three suicide prevention recommendations were all funding recommendations, and none were funded in the legislature's 2017 budget. Whether the task force will take them up again for 2018 remains to be seen, but I did want to tell you just a little bit about them. The first funding recommendation was to increase the number of school nurses. Our state is almost 600 nurses short of meeting nationally recommended ratios for nurses per students in schools. And many don't realize that nurses spend about 30% of their time providing mental health services to students. In that 2015-16 school year, nurses had nearly 1,500 counseling sessions with North Carolina students related to suicide ideation, and thousands more related to other mental health issues. So they do play a pivotal role, not only in this, but obviously in physical health issues that really require attention, and also potentially spotting a child who needs attention for abuse and neglect. So they do play a critically important role. Another recommendation, creation of a school social worker consultant position at the Department of Public Instruction. We actually have state-level positions for school nurses, school psychologists, and school counselors, but we have no such equivalent for school social workers. And that makes it a challenge to collect data. It makes it a challenge to coordinate, to train. And so our recommendation was we need to support the work of these school social workers, which are critical in this, in suicide prevention, if we're going to move forward. And then finally, you heard me talk about the 2015 North Carolina Suicide Prevention Plan that is quite large. Many organizations in North Carolina are currently working on suicide prevention, including government, nonprofit, academic organizations, and there's a lot of robust work taking place. But putting a lead person in place, at least temporarily, to coordinate all these efforts, including funding efforts, would really jumpstart the state's ability to implement the comprehensive strategies that are outlined in that prevention plan. And that's what the task force felt would be important. So moving away from the topic of suicide prevention, I want to give you an example of how the task force brings attention to connected problems and the fact that multiple policy solutions are needed to make an impact. Sorry, skip. This example is the task force's Harmful Substances Initiative. And the idea behind this Harmful Substances Initiative was to make people aware that harmful substances in any form, drugs, alcohol, tobacco, have a significant impact on the health and well-being of North Carolina's children. In fact, multiple causes of death that are studied by the task force have a connection to harmful substances. There are multiple physical, mental, and social problems that contribute to or result from substance use and misuse, and those problems are often interconnected. So our Harmful Substances Initiative is meant to bring attention to the fact that there's a significant impact and there's the interconnection of all these multiple problems, and that's why we need multiple policy solutions. So when it comes to harmful substances, you can't tune into a news source lately, and Donna alluded to it earlier, without seeing something about the opioid epidemic. And while opioids are only one of multiple types of harmful substances, the opioid epidemic is certainly something that the task force has been paying close attention to. This chart represents numbers of unintentional deaths in North Carolina from opioids, both prescription and illicit. And this chart, by the way, is all ages. You can see that in just 15 years, we've gone from seeing under 200 deaths per year to seeing over 1,000 a year. And that recently we've seen a dramatic increase in these deaths. While the number of kids who are 17 and under who actually die from an opioid overdose is very small, especially in comparison to the other age groups, the impact of this epidemic on the adults in kids' lives has a huge impact on kids. So when we look at substance use impacts on children, there are very specific areas that the task force looks at that are impacted by harmful substances. And one of those is child maltreatment. As part of the task force efforts to reduce fatalities, we have to examine and make recommendations concerning child abuse and neglect. And in recent years, we've seen a rise in the number of kids entering foster care related to parental substance use. Another area is infant health. A major focus of our perinatal health committee is the impact of substance use on prenatal health and infants. Whether it's drugs, alcohol, or tobacco, these substances really do have a significant impact on birth outcomes, infant mortality rates, and child health and well-being. Poisoning is a topic of discussion in our unintentional death prevention committee, where much of the discussion focuses on reducing access to substances or addressing poison first aid when it occurs. The Unintentional Death Prevention Committee also focuses on accidents, many of which are connected to alcohol and drug use, or could be connected to. In North Carolina, alcohol is involved in about 1/3 of fatal crashes. And it's estimated that drugs other than alcohol are involved in about 18% of motor vehicle driver deaths. And besides motor vehicle accidents, impairment from substances can be a primary or contributing factor in other types of accidents, including those on watercraft, falls, and other injuries. And then finally, of course, you've got multiple potential negative impacts for youth who use and abuse substances, besides the impact for accidents involving impairment or accidental overdoses from poisoning. Substance use puts kids at greater risk for engaging in delinquent activities, which can involve violent crime. And substance misuse also puts kids at greater risk for suicide. So the task force's Harmful Substances Initiative recognizes that in order to make progress addressing the impact of harmful substances on children, policy solutions from multiple perspectives are required, whether it's preventing access, providing prevention education, providing intervention and treatment when it's already become a problem, poison first aid, integrating our systems that address these problems, making sure that they're talking to one another, making sure that they're working together, and then taking a public health approach, recognizing that this is something like the opioid epidemic is truly, it's a public health crisis that we have to address as such. Here are some examples to illustrate the policy solutions. These are examples of recommendations that have been made by the task force in recent years that relate to Harmful Substances Initiative. funding for safe drug disposal. Operation Medicine Drop is our safe drug disposal program in North Carolina. It's actually a nationally recognized program that's a joint effort between the SBI and Safe Kids North Carolina. They utilize permanent medicine drop boxes across the state. In fact, I think they've actually achieved having one in nearly every county in our state. And they also put on take-back events, drug take-back events. In fact, I believe October is one of the major months in which there will be a lot of drug take-back events across our state. In just 2016, Operation Medicine Drop collected over 13 million doses, which was over 26,000 pounds of drugs for safe disposal. And what a lot of people don't realize is there's money involved in safe disposal. You're supposed to have these drugs incinerated with an EPA-rated incinerator. You have to have law enforcement who's involved in actually transportation and making sure the drugs get to where they're going. And so there are expenses involved. There are charges involved with the incineration, et cetera. So we have supported funding for safe drug disposal. Also, the controlled substances reporting system. That's a very important tool in fighting the opioid epidemic because it allows prescribers and pharmacists to see when controlled substances are being prescribed and dispensed, potentially preventing overprescribing and misuse of controlled substances such as opioids. So there have been a number of recommendations in the last several years that have related to controlled substances improvements and increased use of that. Overdose reversals. There's a drug called naloxone. Many of you may have read about it in the context of the opioid epidemic that can literally reverse an opioid overdose. And since the 2013 legislation went into effect that resulted in increased access to and use of naloxone, and I just checked the website the other day, over 7,400 reversals have been reported. And those are just the ones reported from the distribution of overdose reversal kits. And I don't believe those even count the law enforcement administration. So that just gives you a picture of just how much good that is doing, the increased accessibility. We have also endorsed, in 2017, we endorsed legislation that might arise that was designed to strengthen impaired driving laws. And then funding for UQUIT, TUQUIT, perinatal tobacco cessation program. I've already mentioned that. So that's a very important thing that we have advocated for. So the ultimate goal of this harmful substances initiative is to positively impact infant health and infant mortality rates, decrease abuse and neglect, and the number of children in foster care, and save lives from poisonings, accidents, violence, or suicide. So that's not something that, this is something that we'll be continuing to work on in years to come. So if you hear that phrase, you know where it came from. So through the examples that I've given and use of the data, and I'm just doing a time check here. Okay, we're good. Through these examples I've given you of the data that we use and the kinds of strategies that we use in formulating recommendations and examples of the recommendations, I hope you've got some idea of what the task force does and how we do it. I really could just barely scratch the surface. So as I mentioned, we have a website that's hosted by the General Assembly, and there's a lot more information to be found there. So I invite you to go ahead and dig deeper if you're interested. The task force is truly a unique forum for accomplishing what it's been able to do throughout its 26-year history. I've heard from experts experts in North Carolina who have reason to go around to other states and do various kinds of work, and they tell me just how unique the task force is at providing this forum for bringing together the right people to learn about data and make informed policy recommendations. And what we do is we learn from that data and we try to educate others on causes of child death and strategies to prevent child death and maltreatment. We explain the logic and the data behind the recommendations made by the task force. And we make those recommendations to the governor and the General Assembly as part of our annual report each year. The good news is we really do have the ability to reduce child deaths, and one way of doing that is through policy change. This graph shows that since creation of the task force in 1991, the child death rate has nearly been cut in half. That's a lot of progress over 2.5 short decades. Of course, not all of that progress has been because of the policy work of this group, but the work of the child fatality prevention system and the policy changes advanced by the task force have certainly contributed to this decrease. And where that leaves us, this 46% decrease, in 25 years, an estimated 16,000 more children have reached adulthood in North Carolina than if the rate had remained where it was in 1991. So that's truly something to celebrate. And that's all I have to share with you, and I welcome your questions.